Okay, guys. So, welcome everyone. We'll just today is one of those series of sessions where we are going to try to solve some interesting questions from the recalls and interesting questions from elsewhere, and try to make it interesting for all of you who are preparing for the AKP, FOP TAS. Obviously, some of the questions they're all mixed type, and as you know, for this exam, they're all there's no a lot of the topics and a lot of the types of questions are mixed. They're very blurred, like they're you can't really separate them. So it will be a good mix. So today, obviously, the most of the questions which there are only a few questions which I've selected, which I thought I found in the exam to be coming quite often. So what we'll do, but obviously this is a webinar, so the way it works is it'll be more of a one-man show, but you guys can use the what do you call webinar to the chat to just spare your thoughts. Just write your answers or what you think about the question, or if you have any doubts, and we'll maintain the flow. It's in the end we will have a more formal. We'll have a discussion. If that's okay, and you're happy with that, then just say let's go. Can you type let's go? Then I will start sharing the screen. You just put let's go because you'll have to do it with the we'll have to do it this way because this is the way it will work best really. Okay, now I'll just come to get my thing ready. One second. Give me a second, I'll just get my thing ready. Okay, yes, sir. So we'll go. Let's just try to share. Is it coming on the screen? Just put on the chat. Yes, then I know what's going on. Now, Pooja, you have to mute yourself because I can hear a lot of background noise. Okay. So I can see the chat here. Hello. So let's go. That's good. And good to see you, Tanushree. Good to see everyone. Shravya, Soma, Deepa, obviously been here from the beginning. So all those who come here, we've got about a total of 6 of us. Soma, Tanushree, Shravya, Pooja, you're all here. Okay, so let's make it interesting and share your thoughts in the chat webinar because we won't be allowing you to talk. Okay, just to keep things moving. So we just a few seconds only. So 4 weeks baby presented with bilious vomiting. And then the question, obviously, this keeps coming up in the exam, but let us see if we can think about how we are thinking about the differential diagnosis, because this keeps coming up in the exam. Okay. So what I'll do, okay. Yeah. There. Now, so this is the choice. Just write what do you think is the answer, because you can put your type of message there, right here. You can chat here. And why do we think gut malrotation? Anyone? What would you make you think? It's a bilious vomiting, it could be a lot of things, isn't it? How would you just write your answer why you think it is whatever you are, and Yeah, it's presentation late. Exactly. Malnutrition can be one of the most confusing questions, and there's sometimes you don't get very clear answers. Now, how would you diagnose malnutrition? Yeah, Bill is forwarding late presentation. That's the important thing. And pyloric stress is non-biliary. Excellent. Really good answers. Really good answers. And how do you diagnose? How do you diagnose malnutrition? What are the diagnostic signs? Absolutely, contrast. That's it. So basically, that is the gold standard. All right. You do use a contrast shadow. Now again, this is obviously more detailed. It's saying plain radiograph. You can keep it, get a tube let's not get too confused, but there is saying that double bubble sign of duodenal obstruction, that can of duodenal obstruction, but sometimes it can be signs of interest. They are using it as a signs of intestinal obstruction. USG, obviously, they see a dilated duodenum. There's something called whirlpool sign of volvulus. Yeah. So that is interesting. Upper GI contrast study is the golden thing. And what they're it is a clearly displaced duodenum ligament of trides on the right side. So you have a corkscrew appearance. That's what they're saying. And there's something called beak appearance. So entire small bowel is located in the right abdomen, barium enema. Then again, this complete obstruction of the transverse colon. So basically, I think what you need to know is it's a contrast study if they're showing and they're asking this question. It is a late and it's a bilious. You need to think of, and if it is intermittent, sometimes the symptoms come and go, then we need to think of what you call malnutrition. USG is done, but upper GI is the really the main one. Okay, so let's move to the next one. So let's saying obviously here again it's the one more slide. The investigational choice is possible malnutrition with associated volvulus in a stable unit is the upper GI contrast study. Upper GI contrast study. That's the golden thing. However, the problem in real life is this can lead to delay in surgical intervention and therefore a worse outcome. So this takes time to arrange. And if it's happening in the middle of the night, it can be a problem. So that's why they're saying they did an article basically where they found that duodenal and gastric dilatation, along with limited small bowel gas on the right lower quadrant of the abdomen and total absence of colonic air in newborn indicates the malnutrition of volvulus. These are obviously very advanced studies, but sometimes nowadays in the Royal College exams, they are asking, these are because these are stable subjects. So they will try to trick you by asking, what are the latest question papers, latest research papers, what are the, what are the latest science, because they will not give very straightforward, choices. They will want to see if you're up to date with what's the latest thoughts or what are the latest ways of diagnosing. So we all know it's a contrast, but they are saying because it takes time nowadays, a lot of people are using, the advanced radiologists or experts sometimes use radiographic features. It is duodenal and gastric dilatation, along with limited small bowel gas in the right lower quadrant of abdomen. And there is a total absence of colonic air. So in the newborn, says malnutrition with volvulus. Okay, can we move on? Just say move on, and then I'll move on. Just say type move on, or type next. Move on. Deepa. Thank you, Deepa. Yes, move on. Okay. So then I know whether it's how fast and how slow I'll go. And we don't want to make it too late. So this is the interesting one. And take your time. I'll read it slowly, but this is very important for the exam because this is how the questions are going to come now. 8-year-old boy was on a school trip together with the mother. They had a road traffic accident and sustained injury, and the mother was intubated and admitted to the ICU. The boy came with the teacher and he required an urgent CT scan. There was a man talking to the teacher who confirmed that he was the biological father of the child who was not married to the mother for 2 years, but his name was not in the birth certificate. So the child and the mother had the same last name. Again, I'm saying. So, what is the as a court order? Okay. Pooja is saying court order. So again, 8-year-old boy on a school trip with the mother. They had an RTA, road traffic accident, sustained injury. Mother was intubated, shifted to ICU. The boy came with the teacher and he required an urgent CT brain. There was a man talking to the teacher who confirmed that he was the biological father of the child, who was not married to the mother for 2 years. But his name is not in the birth certificate, though the child and the mother have the same name. Really interesting. So I will just ask very quickly. Why is it? The answer is 1 and not 4. But can anyone say why it is the emergency consultant who is going to be the person responsible for giving consent for CT, and why it's not going to be court order? The answer is obvious. Very clear answer. This is common sense, really. Yes, it's a life-saving procedure. Where is the time for a court procedure? Do you have the time? You can't wait that long. Anyone else? It's a life-saving. So there's no time for court order and everything. You just, someone has to take an emergency decision. The life-saving decision. So in those cases, the emergency consultant, the law is such that it will help. The emergency consultant is allowed to use his discretion. So please understand that depending on the frame of situation. If it's a situation where you have more time to take action, that can, even if it goes to a court or if it's a weekend, it might take 2-3 days, maybe a week. So that, that situation is different. Here, there's no time really. There's no time. All right. So I hope that was useful. Just type useful. If you found that was good, just type useful. Then I know that you're just some love back, really, just some appreciation from you guys. Yeah, good. That's Tanushri. Thank you, Tanushri. It's always good to hear from you. It's good. Yeah. So I feel good now. Thanks a lot after the end of a long day. Thank you so much. Thank you. It makes me feel good. So obviously it was the emergency consultant, and we know why. Okay, so this is so useful. Okay. Very useful. For UK exam, you have to know. Now this is another interesting one, and let's see how you get it. 8-year-old boy was presenting with abnormal head movement and behavioral change. They live in a rural area. The parents refuse any conventional medical treatment. And the last time they went to a doctor was more than a year ago. And the children are homeschooled, so obviously quite rural, and they are away from the mainstream. Father is an alcoholic and is refused in his community. He's basically isolated. So 8-year-old boy presented with abnormal head movement, behavioral changes. They live in a rural part. The parents have refused any conventional medical treatment, and they have seen the doctor 1 year ago. Over a year ago, children are homeschooled. Father is alcoholic and refused in the community. Doesn't have very good relation in the community. So what could be the diagnosis for this 8-year-old boy? Take your time, and you should have an answer, explanation why. If you got an answer, you should type down why you think this. So Tanushri is saying it is SSP. Is it because that one is prominent in bold letters? That might be a trick as well. SSP. Just type a word or sentence why you think that is. That's good. So we agree on that. Deepa says post-measles not vaccinated. Soma says SSP unvaccinated. Yes. So there are certain, very. It is basically you have to get used to the, the trend, the pattern in the UK exams. So if you're untreated, if you're not vaccinated, that's more likely, and they are making it very clear that these are not having any treatment in the hospital. They are homeschooled. They're away from the community. So that's, what are they trying to say? They're refusing conventional medical treatment. And if you're not having this, this is more likely. Why is it not a brain tumor? Why is it not brain tumor? Or like, see, you cannot say it's not, but I'm just saying why, you have to give basically supporting your points more in favor of this or not. That's, and they expect you to be, yeah. So no headache. Yes. So obviously that's a very good answer, because yes, there's no absolute answer, but at least your points for and against. Absolutely. So Suma, very well, I think. No headache. Yes, usually brain tumors, there will be some sort of headache. There will be vomiting, isn't it? Early morning sickness. There'll be vomiting. There'll be convulsion. There'll be loss of vision. They are very typical, and they are focal signs. Yeah. So very good. Thank you so much. Because this, what we're trying to do here is trying to get the understanding right. Because if your train of thought is right, then you can sort it in the exam. Obviously, alcohol ingestion is not the answer. Great, very good. So can we move on? Just type move on. If you're happy with this question, just type move on, and I'll move on. I'm here. Okay. Can we move on now? Yes, move on. That's it. Or just say MO. That's better. MO, short letter. MO is good enough. Yes, good. Okay, so we'll move on now. MO. Now, this is basically the 5. So, do you know the criteria for when you are saying Someone has got SSP. So I've just put some point which I think was important. And you need to see this really. You need to know this for your exams. So these are the 5 criteria, 5 with 3 more. So basically 3 out of the 5 criteria. Then you have got SSP. A lot of questions come on SSP. I'm sure you know that. Deepa knows that. Anyone who's given the exam knows that. So anyone, if it's a clinically progressive subacute mental deterioration with typical signs like myoclonus. Number 2, EEG periodic stereotype high voltage discharges. Number 3, CSF raised gamma globin or oligoclonal pattern. Number 4, measles antibody raised titer in serum or is cerebrospinal fluid, brain biopsy, rest of panel. So this definitive criteria is when you've got with criteria 5 with 3 or more criteria, probably 3 of the 5 criteria. Okay, is that good? Yeah, is that good? Don't you think it's important? Yeah, CSF, we need to know that, isn't it? Okay. So someone is raising hand. You can just chat, okay? Because if I start talking, then we'll get loose. Okay, you can just chat whatever you got to say, and we'll talk in the end. So now changes due to SSP. What happens? What are the changes due to SSP? Behavioral decline, lethargy, inattention. That is stage 1. Temper tantrums, cognitive decline. All right. Then stage 2 is myoclonic jerks, seizures, dementia. So quite bad, really. And then stage 3 is rigidity, extrapyramidal symptoms, progressive unresponsiveness, and progressive unresponsiveness. Stage 4 is coma, vegetative state, autonomic instability, and akinetic mutism. So we need to have a fairly good idea of what SSP is involved. Okay, we'll move on from there. Measles, as you know, that's caused by paramoxyvirus is the problem. Yeah, improvement of exanthem with fine discoloration after 4 to 5 days. So a lot of times you'll get questions where they will give you the features of measles, and then it will lead you to SSP. So that's the reason I put on the the things about SSP. Symptomatic vaccine. So basically, course of the disease incubation period is 14 days. Contagious period is, as you can see, this 14 days. And onset of exanthem is somewhere here after the end of 14 days. It carries on for 4 days. Now, if you look on the screen here again, you do get exanthem on palate and Koplik spots. They do give a lot of questions based on that. And exanthem, basically erythematous maculopapular rash, which is blanching and partially confluent. So they have given a picture. And obviously it's high biphasic fever, there's a barking cough and reduced general condition. So, we should measles, we need to have a good idea. Okay, so moving on. Now this is another interesting one. Neonates with irritability, sweating, heart rate 300, capillary fill 2, is stable, well and alert. What is the next step in management? So basically you need to know, so all those are doing neonates should know really. If you're having SVT, heart rate of 300, capillary fill 2, stable, well and alert, what would you do? How do you manage this child? Tanushi says 1. Pooja says 1. Is it because it's prominent? Is it bold letter? Is that the way? Is it not adenosine? So tell me, why is it not adenosine? This is an open question, really. There's no definite answer. I just wanted to see how you can justify. So we are divided. Deepa and Soma says adenosine. Tanushi says Pooja. Pooja says ISPAC. Can everyone, all of you give just one question, 1 point in favor of why adenosine or 1 point why in favor of ISPAC? First line is vagal maneuver. Yes. First line is if you're stable child. Yes. If a child is stable and alert, then the first line is vagal maneuver. So that's pretty good actually. So now again, I talked to my my neonatal consultant and he was saying adenosine because he said that's what practically works. But I think if your child is stable, I think that's what they're trying to say. If it's sweating, the stable child, well and alert. Then for theoretical, in practical situations, they do give adenosine. But I think for exam purpose, we need to, think about, and that's why they're saying stable. Now let me just show you what they're saying here. So how is ventricular SVT treated? Most episodes of neonatal SVT, they will only last for a few minutes and they do not need urgent treatment. And so those who are affected longer, you need to stop or reduce the chance of prolonged period of SVT. There is often a beta blocker which helps that. But other medicines are, you need to know this as well, flecainide, digoxin, and amiodarone. So these you need to know. It's important also to check the heart rate by taking their pulse. We teach parents to do this well. So vagal maneuvers. So sometimes the parents are taught how to do this, like work on the vagal nerve, which regulates heart rate. Now, if an episode, sorry, one second, one second. If an episode lasts for a prolonged period, over 20 minutes, treatment may be needed in hospital. Often this involves, so more than 20 minutes, you go to hospital. Then it will be injection of medicine called adenosine or exposing a baby to ice. And obviously, if it's involved in several hours, then you need admission. So I guess with this way, that is what the information we've got. Okay, that's the information we've got. So basically, if it's a prolonged period, over 20 minutes, then you might have to go to hospital. In that case, just giving vagal maneuvers at home or putting ice in at home would not be the right thing. And there they are saying, they have said both the things. They have said it involves injection of medicine called adenosine or exposing a baby to ice. Okay. And if it's only several hours, then you can admit the child. So, so we'll have to make an answer from here really. So, and depending on what they are saying, it's unstable or stable child. So are we happy with this one? Should we move on? Yeah, guys? Just put MO if you want me to move on. But SVT keeps coming in the exam, and you need to have fairly good idea. Keeps coming in the exam. Now, this is another important question, which I found, because these I found keep coming again and again and again and again. And you really need to have a good idea. So, infant presented with cleft palate, poor feeding, heart murmur, subtle facial dysmorphism. Now, I did not give the face, but anything you can make out. Cleft palate, poor feeding, heart murmur, subtle facial dysmorphism. Which one of them has cleft palate? Now, I think what we'll do, yeah, period of when someone is saying. So I think the main thing is we need to know what, with which each syndrome, what does it comprise of, and that will be the answer. So, everyone is saying DeGeorge syndrome, cleft palate, poor feeding, heart murmur, subtle facial dysmorphism. And you've got people are saying Perry Robin. Now, the answer is DeGeorge's, yeah. Now, obviously, I haven't got the picture here, but let's see what it is really. Just because I found these are the very best way you can study for the exam, because they're such a nice, wonderful way they summarize it. So DeGeorge is velocardiofacial. So velo means cardio and facial. So I guess vertebral. So cardiac defect, catch-22, abnormal face, you got hooded eyes, ptosis, hypoplasia of auricles, thymic hypoplasia, you can see in the X-ray, the thymic hypoplasia, cleft palate. The cleft palate is definitely DeGeorge's. Parathyroid hypoplasia, hypernasal speech. It's called velopharyngeal incompetence. I was not aware of what the velo stand for, but obviously it is the hypernasal speech. Hypotonia in infancy, learning disability. So that is, that is what it stands for. One second. Okay. Yeah, so heart condition is definitely DeGeorge's, and obviously you got cleft palate. And sometimes they will in the exam, they will give you the ears, they will give the face, and this is what they give you, the X-ray. And you can see there is no thymus. So that is how it is. Now, common cardiac, what are the cardiac defects? And a lot of questions come up on what is the cardiac defect. You get a lot of MCQs. Interrupted aortic arch is very common, truncus, arteriosus, tetralogy of Fallot, and VST. So interrupted aortic arch, truncus, arteriosus, tetralogy of Fallot, VST. What do you find in the lab? Hypocalcemia, low PTH, and low IGP. These we always remember. DeGeorge's, we always remember hypocalcemia, low PTH. Sometimes we remember it is also interrupted aortic arch. And thymic hypoplasia, but I think we forget cleft palate. And parathyroid aplasia, and we obviously, hypotonia is important. Hypernasal speech, that is velopharyngeal. So when they say velopharyngeal, that's what it means. More dominant is autosomal dominant. There's something to do with 22 deletion syndrome. And as I say, most common microdeletion disorder, T-cell disorder. Which vaccine should be avoided? Live attenuated vaccine if immunodeficient. Okay, so that is your DeGeorge's. What is Perry Robin sequence? I found this picture really good. The congenital birth defect that occurs during fetal development. Basically, is the tongue. It's a backward position tongue. That's what it's all about, really. And micrognathia, as you know, this chin is going through underdevelopment of lower jaw. Lower jaw should have been here, it's pushed back. And obviously, because the tongue going back, there is airway obstruction. The cause is not fully understood, and there is some isolated genetic mutation syndrome. And sometimes it's a Stickler syndrome. That's what we are associated with. So that is what is period often. Williams, again, this keeps coming up in the exam. And I found this picture. I hope it is useful for you, like I found it useful. So you get a blue eyes with starry pattern. That is very typical. Periorbital puffiness, sunken nasal bridge, short nose, smooth philtrum, widely spaced teeth, prominent lower lip, small chin. Now the cardiac problems are supravalvular aortic stenosis, hypercalcemia, low birth weight, developmental delay, short stature, increased incidence of umbilical inguinal hernia, hyperacusis. Hyperacusis. Okay. So these are fairly very good features. Just remember blue eyes with starry pattern. That's very typical. Prominent lower lip and small chin is typical. Smooth philtrum is a typical thing which keeps up coming up in the exam. And obviously hypercalcemia, supravalvular aortic stenosis, hyperacusis. So these are the very typical ones. Smith-Lemel-Opitz syndrome keeps coming up in the exam. Now I found this one helpful. Autosomal defect in C7 reductase. This is some sort of cholesterol biosynthetic enzyme problem. There's a high forehead, narrow temples, with a drooping eyelid, broad nasal bridge, upturned pointing nostrils. Behavioral characteristics. Basically, the main thing is they have got repeated self-injury, prolonged temper tantrums, and violent outbursts. So just be aware of that. It's quite related with a lot of self-injury, prolonged temper tantrum, violent outbursts. So there's a lot of behavioral problems here. That is Smith-Lemel-Opitz syndrome. Obviously, you have to remember the facial features as well: high, broad forehead, broad nasal bridge, upward pointing nostrils. But these are the important points. Now, central precocious puberty and peripheral precocious puberty, because that was one of the choices as well. So I thought we need to have a very quick idea because a lot of questions come up on the central and peripheral precocious puberty. Central precocious puberty is gonadotropin dependent, this one is independent. The premature activation of gonadotropin release hormone first generator. In obviously girls, which is the precocious puberty in girls, usually there is no underlying cause, you don't need to panic. But in boys, it's always pathological. In the boy, you're having early precocious development of puberty, there is always some tumor or some problem going on. And so what are the causes? Idiopathic, CNS tumors like osteocytoma, glioma, germ cell tumor, hypothalamic, hamartoma, too many things. CNS injury, surgery, trauma, irradiation, inflammation. So one is CNS tumors, one is CNS injury, another is congenital anomalies like septo-optic dysplasia, arachnoid cyst, and neurofibromatosis. So these are the for central precocious puberty. Brain MRI and pivotal response hormone LHRH, then GnRH, analog, these are all done for the investigation. Peripheral precocious puberty is another one. It's another entity, gonadotropin independent, excessive production of androgen and estrogen. The causes are McCune-Albright syndrome, testosterone, tumors, and late onset. And obviously, you've got abdominal pelvic CT or MRI. Cypriot and abscessed is in the treatment. Okay, so let's move on. I think we just got a brief idea. Just a few more questions and we'll finish. Getting late now. So 8-year-old boy, I hope you guys are still here. Yeah. So let's move on then. 8-year-old boy with a height on 90th centile, weight on 91st centile. Great. I thought some people have dozed off. So great that you're here. 8-year-old boy with height on 90th centile, weight 91st centile. Scenario with pubic and axillary hair. Now, blood pressure 125/78, testicular size was 3 ml. Now, obviously, this was one of the recall papers, so I also couldn't find this picture, but I have definitely remember in my exam as well. We used to, this thing keeps coming up. A picture of a virilized male genitalia. Okay, so like a premature, virilized male genitalia. This keeps coming up very often. Sorry. One second, excuse me. So obviously you are saying premature adenarche. You just says three congenital. Obviously the answer sort of went by. CH is congenital adrenal hyperplasia. Now you need to say why really. Okay. So where do you get a 8-year-old boy with high blood pressure and early development of pubic and axillary hair? One. It's not one. That's congenital adrenal hyperplasia. Okay, CH. That's the one you need to go. So what's the meaning of testicular size 3 mm? Then you've got hypertension. Where do you get hypertension? So these are all the clues which you have to add together and then come up to the final picture. See, if it's a hyperhamartoma, then all the hormones will be less. Central hormones will be less. Everything goes down. So the testicular size 3 mm, they are trying to, so you have to go back to your, what size stands for pubertal or pubertal, that sort of thing. So obviously, peripheral precocious puberty, that's what it is actually. Hypertension, congenital adrenal hyperplasia. That's what it is really. So now I thought go through that, but also this, I don't know why, for some reason the Royal College loves to ask, they keep on coming, giving questions about premature adenarche. And I never knew the answer. I always forgot it, always. So do you know what is premature adenarche? Because believe me, it keeps coming in the exam again and again and again. I've been teaching for 10, 12 years. Keeps coming in the exams. I don't know why. It's the appearance of pubic or underarm hair in girls younger than 8 years or boys younger than 9 years. That is premature adenarche. And you get adult type of underarm odor, often requiring use of deodorants. Okay. Absence of breast development in girls or of genital enlargement in boys, which is present often points to the diagnosis of true precocious puberty. So basically, if you're getting a child, a girl younger than 8 or a boy less than 9 who are having the underarm odor like adults, but they are not having features of either breast development, which is started in girls, or genital enlargement in boys, because then it would go for true precocious puberty. And it's something about height as well, which might be height. So that is when you develop premature adenarche. So it is like a not true precocious puberty, just the underarm odor and the pubic hair. So that is where you need to just be aware of this term. So again, I found another place where this one came up. Early appearance of androgen mediated skin changes, any combination of pubic hair, axillary hair, body or odor, oily skin, oily hair, mild acne in either boys or girls. So just remember acne, body odor, oily skin, oily hair. So either of them. No clitoriomegaly in girls. No larger than pencil areas or less than 5. So obviously clitoriomegaly would be standing more for precocious. No acceleration, height growth or advanced bone development. Because bone development more than 2 standard deviations about the mean, they are definitive signs of, there's some sort of precocious development happening. So that's that. And again, the other choice was congenital adrenal hyperplasia, which we know the adrenal glands are here, right on the top of the kidney, the healthy gland. And hyperplasia, again, you get excessive adrenal gland, and you need to be aware of what that stands for. We went about central and precocious puberty. Now, it's just another slide which I thought was very useful, which keeps coming up in the exam. One is alpha fetoprotein, where you get a neoplasms and non-malignant diseases. Alpha fetoprotein will keep coming up in the exams in different ways. So neoplasms you get in hepatocellular, gastric colon, pancreatic, and biliary and lung carcinoma, liver metastasis. So it is all alpha fetoprotein. Mainly to with liver, gastric colon, pancreas, biliary, and lung carcinoma, liver metastasis. Non-malignant disease, where do you get it? Virus hepatitis, liver cirrhosis, fatty liver, hepatitis, ataxia telangiectasia, hereditary tyrosinemia. So these are gold, I would say this is a gold, gold nuggets really, because it's very common. HCG. So there are a lot of questions on HCG. In fact, we'll get one very soon right now. So you get in non-malignant disease, it is in cannabis consumption, hydatiform mold, hypogonadotropic hypogonadism. Whereas in the neoplasm, it is pancreatic islet cell tumor, intestinal stomach lung, ovarian, renal, and so many carcinomas, hepatomegaly, and Hodgkin's, non-Hodgkin's, so many of them. HCG is a huge amount. Myeloma, lymphoma, melanoma, pancreatic islet cell, intestinal stomach, lung, ovarian, so many things going on. And non-malignant is obviously cannabis consumption. Sorry, high retiform mole, hypergonadotrophic hypertension. This is where LDH is obviously leukemia. That's where you worry about leukemia. And non-malignant stands for skeletal muscle. Is this useful, guys? Is this form? Do you think this one is useful? This particular slide. Are you still there? Are you still awake? Right, Pooja is awake. Tanushri is still there. Okay, Deepa is still here. Thank you. So I think this was useful, and this we can, it does keep coming. Soma, thank you for answering, because you are giving me the energy to go come next week with another presentation. I plan to make this a regular thing for you guys. Okay, go through all the past papers, interesting questions. I hope you look forward to that. Yeah. Okay. So now 9-month-old boy with failure to thrive at 4 months started solid food. At the age of 5 months, his height and weight began to decrease. He was constipated. Mother changed the formula milk, and the baby also took laxatives that did not help. Urine showed glycosuria, proteinuria, bicarb 11, ALP 1300. What is the most appropriate diagnosis? So basically, 9-month-old failure to thrive. 4 months, mom started to. So basically, at 4 months, mom started solid food. Okay. And at the age of 5 months, his height and weight began to decrease. He was constipated. Mother changed again the formula. And the baby also took laxatives that did not help. Urine showed glycosuria 1 + 1 and proteinuria +1. Bicarbonate 11, ALP 1300. So what's the diagnosis? Cystinosis, Williams, primary hyperparathyroidism, hypophosphatic rickets, celiac. Come on. Who knows the answer? Anyone? Tanushri, Deepa, Pooja. Cystinosis? Yes, now we need to know what cystinosis. Anyone else? Yes, Deepa also cystinosis. Yeah. So what happens in cystinosis? That's the right answer. So see again, these are the typical questions which come in the Royal College and which we are very vague about, because in India we don't see these things. So Deepa is saying cystinosis because of glycosuria as well. And you get proximal renal tubular acidosis. That's very good. So you're getting there really. So just remember these pictures really. It's basically collection of crystals, cystine crystals in the body. So you can see the crystals collecting in the body. And affects the defects in the CTNS gene. It is the defect in the CTNS gene. And what happens in the defect? That causes the thing. Deletes the CTNS gene, preventing cytosine, cystinurin from working properly or from being produced in light amounts. So cystinosis is basically rare autosomal recessive, lysosomal storage disorder, abnormal accumulation of amino acid cystine crystals. You can see the cystine crystals here on multiple organs of the body. And the defect is in the CTN gene, and cystine obviously had a when amino acid builds up in the lysosomes. So amino acid keeps building up in alarming levels. The accumulating cystine forms cystine crystals in almost all the tissues and organs in the body, subsequently affecting their function. Basically, it gets converted into the crystals, and that affects the whole body. It's bad. Basically, what is cystine? Amino acid build up in the lysosomes. Okay, hope that means so. And it's harmful. Obviously, cystinosis, amino acid gets trapped in the body, damage to every part of the body, and person may not feel the damage, but it may happen without any symptoms. So it is harmful. We need to reduce the level of cystine. If you see the different symptoms in infancy, adolescence, and adulthood. So one is always remember renal Fanconi syndrome. So starting at 6 to 12 months. If anyone knows what is renal Fanconi syndrome, just put a message in the board so that others will know about it. Because in Royal College, you keep getting, Royal College, these are you need to have an idea of the progress of the symptoms of stenosis. When infancy is basically renal Fanconi syndrome, rickets from 6 to 1 month, and growth retardation, very clear-cut features. Adolescence, photophobia, hypoparathyroidism, GI start, kidney failure. Adulthood is blindness, you can myopathy, swallowing, diabetes mellitus, and memory, concentration difficulties, pathology difficulties, muscle tone loss. So these, I hope this cystinosis symptoms give an idea. So cystine crystals have recently been shown to act against the The immune system causing a chronic inflammatory process, apoptosis and oxidative stress. Cystinosis treatment can slow down but delay the effects, but it cannot halt the overall progression of the disease. It can slow things down, but the overall progression will be carrying on. Cystinosis remains incurable at this stage. Okay, so we need to know what is cystinosis. There are three types of cystinosis: infantile type. Okay, this is the most frequent 95 presentation, and this presents as Fanconi syndrome, renal Fanconi syndrome. We'll cover the next time. Intermediate cystinosis is basically a small group of patients that can present with proteinuria and mild or absent tubulosis. So it can lead to renal failure slowly after some time. Now there's something called ocular non-nephropathic cystinosis, benign cystinosis, and some doctors know them from childhood. It's very good with the patients. So basically you have to be very good in the sense that you have to check the eye, and typically involves the presentation of photophobia due to collateral accumulation. So these are the three main types which keep coming up in the exam. All right. And how do you diagnose it? Elevated cysteine levels in the blood via cysteine test. And these are things you need to know for the exam. These keep coming up in the exam. Okay. Keep coming up in the exam. Let's see. You want to see the question one more? Okay. Very quickly, you see the question. So let me finish the diagnosis part first. Three main diagnostic factors. One is the standard is elevation of cysteine levels in the blood cells via white cysteine test. This is the main important test. Genetic testing of the CTNS gene. Flat. And third option, anyone can tell. That is, that the cordial, what we heard in college days, slip lab examination. So that's what you need to know. Now, coming to towards the end, teenage patient presents with recurrent headache. Yeah. So that was a good thing. Tanushi says that answer the question. Eyesight present very good. Proximal renotubular acidosis. Very true. Very true. And Fanconi syndrome. That's what you get. Okay. And if you wanted to see the question once more, I'll go through this. The question once more. Here you are, the question. 9 months old baby with failure to thrive, 4 months, mom started solid food. So these basically the problems happen as soon as you start solid food. That's when the situation start developing. And at the age of 5 months, his height and weight gain began to decrease. He was constipated. And the mother changed the formula milk, and the baby also took laxatives. He was constipated, mother changed the formula, laxatives. Urine showed glycosuria 1, proteinuria 1, bicarb 11, ALP was 1300. And then you had to change the diagnosis. You can see the choices. Hope that is okay. Pooja, you want to see the question? Okay. Now we just want to respect her because she, the what do you call? It's an important diagnosis which cannot be missed. So you need to have, especially in the UK exams, these are common things. So you need to have fairly be able to catch this one. Okay. So as you know, you're happy for us to move on. Yeah. Now, cysteine crystals have, as I said, because the immune system, they can stimulate the immune system, and that can cause inflammation. And basically, the cystinosis treatment can slow down and delay the effects, but it cannot have maximum change on overall progression of the disease. So, for all practical change, it is an incurable disease for now. Okay. Three forms, I think we talked about infantile, classic cystinosis, and Fanconi syndrome. So these are already been through that. Okay. We talked about diagnosing. The diagnosis of cystine is also very commonly asked in the exam. Three main diagnostic modalities. One is detection of elevated cysteine levels in the blood cells of white cysteine test. Okay. First standard is detection of elevated cysteine levels in the blood cells via white cell cysteine test. So also in the diagnosis and in the levels on systemic therapy. Genetic testing of the CTNS gene is a well-established revealing technique which is causing 95% of the disease. Helping diagnosis. Third option is detection of cysteine crystals found on the cornea by slit lamp exam. examination. So three main tests. One is the elevated cysteine levels in blood cells, genetic testing of CTNS gene, and detection of cystine crystals from cornea by slit lamp examination. Now, coming closer to the end, teenage patient presents with recurrent headaches, vomiting, and oral pigmentation investigation. Sodium 123, potassium 5.6, urea 12, creatinine 16. What investigation would help these diagnosis? You can calm down now. You can now think about, what it is really, because these are physiology stuff which we have studied long back, but we need to know. Teenage patient presents with recurrent headaches, vomiting, oral pigmentation. Okay, sodium 123, potassium, what is it? Low sodium, high potassium. Okay, which investigation will help you to reach the diagnosis? For that, first what is the investigation and what are we thinking about? Vomiting, recurrent headaches, oral pigmentation. Any ideas? Someone is saying, Tanush is saying ACTH short. Where do you do the short synaptin test? Which condition do you do short synaptin test? Please tell me. Any idea? Where do you do the dextrosolution suppression test? These are basic questions for the exam. So adrenal insufficiency you do but what test do you do? Where would you do the short synaptin test and where would you do the dextrosolution test? That's what they're trying to find out. Where do you do what? So obviously this is what the diagnosis is what? Adrenal insufficiency, as you can make out of this patient. Yeah. And what we do is ACTH short synaptin test. That's what we do. Okay. Pigmentation, vomiting, recurrent headaches, low sodium. The signs of Addison's. You do the ACTH short synaptin test. In Cushing's, you do dextrosolution suppression test. Am I right? Yeah. Yeah. So ACTH short synaptin test to see whether the central cause or not. Now, the dextrosolution suppression test is used to assess adrenal gland function by measuring how cortisol levels change in response to oral dose or injection of dexamethasone. It is used for diagnosing Cushing's. Okay. You can see dexamethasone, they have wonderfully shown the diagram. So dexamethasone acts like cortisol, lowers the amount of ACTH released by the pituitary gland. So normally pituitary makes less ACTH, the adrenals makes less cortisol. That's the normal thing. Now in Cushing syndrome, we're giving dexamethasone, which acts like cortisol, and then the pituitary makes less ACTH. So you should stop, if you're making less ACTH, then the adrenal gland should still produce less cortisol, like here. It should produce less cortisol. In Cushing syndrome, what happens? Adrenals still producing excess cortisol. Still producing excess cortisol. So this is what it is. Addison's disease, what's the problem? Fatigue, irritability, depression, lack of appetite, rash on skin, nausea, vomiting, and obviously there was a muscle gain as well in Addison's. You've seen that. And there is joint pain, there is nausea, vomiting, and lack of appetite, as you know that. Okay. What else you get? This is another picture I found very useful for Addison's. Extreme fatigue, weight loss, hyperpigmentation. Because believe me, the number of times this question keeps coming up, you'll be shocked how many times this comes up. Sorry again. Almost having the air. Sorry. Sorry, I don't know what happened. So here we were, extreme fatigue, weight loss, decreased appetite, hyperpigmentation, low blood pressure. This is all Addison's. Salt craving, hypoglycemia, nausea, diarrhea, vomiting, abdominal pain, muscle and joint pains, irritability, depression. Just see what the time is now. It's about 9:36. Okay. And depression. women's sexual dysfunction and body hair loss. So these are signs of Addison's disease. So just to say what Addison's disease happens. The Addison's disease basically normally what happens? Hypothalamus, you get the CRH, pituitary gland stimulation, ACTH is produced, and it stimulates adrenal glands and it produces more cortisol. Okay, so this is what you get. Normally, in Addison's, what's happening? We have got the hypothalamus. You've got the hypothalamus producing corticoid releasing hormones, the pituitary as well. It causes the pituitary to secrete excessive and ineffective amounts of ACTH. It goes down to, supposed to go to the adrenal glands. Okay. Now, Addison's, what's happening? Releases the cortisol, but basically, adrenal cortex hormones are not released really. Hormones are not released. All right. So there's low release of hormones, cortisol. I hope this is, but you get excessive amounts of ACTH because it is trying to stimulate and stimulate. So it sends more ACTH, but the adrenal gland is sort of ineffective. It is not responding to that. Is that clear? Yeah. Adrenal insufficiency, is that helpful? Okay, so have we had enough for today? Or you want to continue? Have you had enough? It's 9:30 now. And we'll do the next one, I think, next time. We've got a few more interesting questions. Should we finish for now? Or Tanushree wants to continue? We'll just do one more question. Yeah? All right, so we'll do one more question and finish. Okay, we'll call it a day. So the short synaptin test in adrenal insufficiency can be used as a screening procedure for non-critical illness. It is basically to detect adrenal insufficiency. And they use the measurement of serum cortisol before and after injection of ACTH. Basically, you're trying to see whether the adrenal gland is doing its job or not. That's what you're trying to see. And if there's a measurement, if there's a less than cortisol, less than 420 nanomoles, 30 minutes post-synaptin, then if it is greater than 420, because adequate adrenal, that means adrenal gland is working. If it's not, if it's less than that, then it is not working. Then you have Addison's disease. So here you have another picture. This is the hypothalamus, pituitary gland, and you can see the adrenal glands, the pituitary gland. As the level of cortisol rises, it turns down the amount of ACTH made by the pituitary gland. Okay, ACTH from the pituitary gland stimulates the cortisol, the adrenal glands to make cortisol. So this comes down here, asks them to make more cortisol. As the level of cortisol rises, it turns down the amount of ACTH made by the pituitary gland. So that's how the system works. This was the last question. I found it a bit tricky, and I think I'd asked Deepa for help with this one. But see what you think. Whether you can come up with answers. This will be, I think, for today. This will be the last one. Okay, we'll finish now. Look very carefully to the question, and I will see how you give the answers. How you think about the answers. Very important one, because in the exam this can come in various ways. 14-year-old girl has a boyfriend. She's sexually active, but I don't know. It just says denies sexual contact. I don't know what that means. It's just from one of the recall papers. But anyway, complaints of recurrent headaches, amenorrhea for 3 months, nausea, vomiting, high HCG in urine, low urine osmolarity, low T4, normal pelvic and abdominal ultrasound. Now, what investigation would you do to confirm the diagnosis? So they are giving you 3 choices: MRI brain, transvaginal ultrasound, serum HCG. I repeat the question: 14-year-old girl, boyfriend, sexually active, complaints of recurrent headaches, amenorrhea for 3 months, nausea, vomiting, high HCG in urine, low urine osmolarity, low T4, normal pelvic and abdominal ultrasound. What investigation would you like to pass? Then what confirm a diagnosis? You've got 3 choices. 3 choices: MRI brain, transvaginal ultrasound, serum HCG. First, tell me, why have they mentioned transvaginal ultrasound? Where do you get high? And ask, my question to you is, where do you get high HCG in urine? Which conditions can cause high HCG in urine? Pregnancy, yes. Pooja Pranti is right. Where else do you get high HCG? It is a tumor marker, isn't it? HCG is a tumor marker. Where else do you get it? See, it's no use just saying MRI and that's the end of the matter. Unless you understand these things, next time you'll get a question in some other way and you'll just totally fail the question. So you need to know the basics. Where do you get highest? Germinomas, yes. Germ cell tumors. Germ cell tumors. Where do you give me an example of germ cell tumor? The early pregnancy can be ruled out in transvaginal ultrasound. That's right. What happens in, have you heard of Fourier carcinoma? Yeah. Yeah, teratoma is a, what happens in teratoma? What goes, just a germ cell tumor. So what goes high? Yeah. What will go high in teratoma? Then again, alpha fetoprotein. Where does alpha fetoprotein get high? And where does HCG get high? Hydatidiform mole. Yes. Very good. Fourier carcinoma, hydatidiform mole. What gets high in these ones? Let's have a look at the slide I had done before. That's why there's a reason I showed you the slide before this. If you have, if you, I don't know if you paid attention to that. But there was a slide I showed you. It just showed which one goes high. I talked about, there you are. Remember this one? Alpha HCG. Let's come to HCG because that's the first one we wanted to talk about. HCG is in pancreatic cell tumor, intestinal, stomach, lung, ovarian, renal, urothelial, mammary carcinoma, hepatoma, retroperitoneal sarcoma, melanoma, Hodgkin's, non-Hodgkin's, lymphoma, myeloma, leukemia. Such a big list. Obviously, you've got cannabis consumption, hydatidiform mole, hyperphonia. These are already there. Where is it with? These are obviously non-malignant disease. Cannabis, hydatidiform, non-malignant. Now, neoplasms are mainly AFP. Let's go for AFP. Alpha fetoprotein keeps coming in the exams various times in various ways. Hepatocellular carcinomas, gastric colon, and pancreatic and biliary and lung carcinoma, liver metastasis. This is where your AFP is very important. Non-malignant disease basically hepatitis, ataxia telangiectasia, and hereditary tyrosinemia. This is where they are non-malignant disease. LDH is basically high in leukemia. Be very clear about it. In the exam, you will get these questions. And non-malignant disease, skeletal muscle disease. So LDH is in leukemia, skeletal muscle disease. And HCG, human chronography, is high in pancreatic cell tumor, what do you call the islet cell gastric carcinoma. A lot of variety of stomach, lung, ovarian, renal, urothelial, retroperitoneal, so many. Hodgkin's, non-Hodgkin's, they're all HCG. Okay. Hope this one helps. Yeah. Okay. I think for today, I think we did this also. 16 also. That's we covered this. We covered this. I think we covered a fair lot of stuff today. So now then we're talking of craniopharyngioma and benign slow tumors, okay? Compression of the nerve, then we might get the vision defects. This is the craniopharyngioma, and it is between the pituitary gland and the hypothalamus. And if your got a tumor is near the optic nerves, you can have visual problems, so that's the very important thing you need to. And craniopharyngioma symptoms are including headache, nausea, vomiting, change in personality, all sort of things. The diagnosis of craniopharyngioma is through hormones which are meant to raise growth hormone, thyroid hormone, androcortic hormones, and just check the levels of sodium, calcium, potassium. And you do get diabetes. Just remember, you do get diabetes insipidus in craniopharyngioma. So you have to check the urine concentration. And tumor markers, especially alpha fetoprotein and beta HCG, those are important. So rule out the presence of germ cell tumor, which may be confused with craniopharyngioma. Okay. Right. So I think that's it. I think we'll finish it here. Now I talked about three, I just stopped sharing screen if that's all right with you guys. And I just see what you're saying in the chat. Deepa says HCG elevated in intracranial germ cell tumors. Exactly. So intracranial germ cell tumors elevated, and that's why I found this question very confusing. But I hope you are clear about it. Okay. I'll just stop sharing. One second. Okay. Okay. And so there you are. Now, I don't know why Pooja is coming here. One second. Super. Okay, so any thoughts, anything? Now, Tanushree starts where to start from in AKP preparation. Okay, so what I would suggest, let me just see why my camera is not working. There you are. And let me come on the view. There I am. For some reason, you just come on. Let's 1 second. 1 second. Sorry, guys, just let me get used to this system. So, Pooja, I don't know why your name is coming from the screen. Guys, can you see me? Am I there?
Yes, sir.
Okay, you can see me, no? Now, all right. So for some reason, I can only see now only, yes, now and audible. Yeah, you can see me. Okay. For some reason, okay, Deepa and all this come. So basically, you guys are also coming. Right, okay. What I will do is one second. Yeah. Okay, there. So I will just answer a few things. Okay, so thanks for being there. Now, Tanushree asked a question about how do we prepare for AKP? Okay, how do we prepare for AKP? So I think what, from my understanding, AKP, a lot of AKP is to do with what you're doing in your hospital practice. Okay, so all the data interpretation books you can get hold of, there are a few there. One of our first recommendation is the RC, the Royal College book on data interpretation. That book is absolutely vital. Go through also books like Paul Guan, which we use, I think, which is a standard book which you should use all the time. Because in Paul Guan, you will get through certain sections, which is like a section which just deals with cardiac catheterization values and stuff like that. There's a section which goes through what are the common types of EEG, which keeps coming in the exams. Because in the quickest way to score marks in the AKP is to get used to pictures. I did today, obviously, I didn't do too many pictures. So go through as many CD scans as possible, as many MRI scans as possible, things which are common in the exam, as many, dye tests for the, renal dye test for, suppose it's a urethrostril or it's a, like, could be a, what do you call hydronephrosis. It could be a pyelonephritis. It could be a renal artery stenosis. It could be a DMSA, DTP. These you have to be very clear about. You have to see again and again and again, because in the exam you have to do it as quickly as possible. I personally felt that dermatology was my interest, and I found if I go through lots of questions on pictures of dermatology, like simple things like streptococcal skin infection, like gold class, things like blisters, what types of blisters, things like staphylococcus skin syndrome, where it keeps coming again and again and again. Things like, skin, again, the skin things are like, you do get, what do you call, eczema, various type of eczema. Obviously, blisters keep coming up in different forms. Also, things like Mongolian spots, simple things like that. So that is the skin part. Go through all the retinal scans. Okay. What's the retinal appearance in a case of toxoplasma? What's the retinal appearance in case of tuberous sclerosis? What about in glomerulonephritis or in diabetes, early diabetes? What are the retinal changes you get? So these are the ones you would be expected to know very well. So just make a list. These are the retinal scans I need to be familiar with for this exam. These are the ECGs, like SVT. First grade 1 block is what you call heart block, grade 2 heart block, grade 3. Those common ECGs, SVTs, go through different types of EEGs. So these are very easy to, they don't take much time. I would say Paul Guan, it's very briefly compressed, all this essential information. Blood gas analysis, ventilation, basic settings, basic settings. So they will give you a blood gas analysis picture, and you have to know when to use the ventilator, rate, when to bring the pressure down. Okay. Acid-based analysis, in real life, you have to use it as well. In the exam, it keeps coming up as well. Okay. So these are the basic stuff which you need to know well about. And the more you do the question papers, the the recall papers, you will get better and better at it. Obviously, variety of X-rays. Now, again, I have to, because see, now I said in the beginning that there was 3 secrets I want to talk, and I'll finish it because we're coming to 10 now. So I'll have to keep my word. What about the 3 secrets? Anyone can guess? I just want some, before we'll finish in about 5-7 minutes. So anyone can guess what are the 3 secrets to crack this exam, especially the AKP or this theory, especially AKP. Any suggestions? Anyone can, what are the, just type what are the most important 3 things to do to crack the exam? Number 1, Tanush, you're absolutely right. Familiarity with the picture. So I've asked a lot of people who passed the exam how they did it. You know what they did? So Down syndrome, they went through a lot of Down syndrome pictures. So that because it's different, no? Every child with Down syndrome is different. Williams syndrome, because these are very basic. So they went through all sorts of Williams syndrome, quite a 10, 12 Williams syndrome pictures, so that you identify what's the common feature. Then if it's a, Marfan syndrome, okay, they went through several pictures of Marfan syndrome, Angelman syndrome. So that was the way they familiarized them. The eye got used to it. So pneumothorax, so several pneumothorax pictures of chest X-ray. Intestinal obstruction, go through as many intestinal obstructions, because these are basic. And you will, if you can't, because in the UK exam, they assume that you're actually sitting in the ward and you can't identify intestinal obstruction. How would you pass the exam? You can't even identify a blood gas basic analysis. You can't even identify MRI scan, which is subdural or extradural hemorrhage. You do a CT, your retinal scan, you are supposed to, in the UK, you're supposed to do basic retinal eye examination. And, the toxocara appearance, or as I said, hypertensive changes in the eye, these are ones you're supposed to understand. All right. Blood sugar, so these things you have to get familiar with. As I said, dermatology, there are a variety of things. We talked about, skin changes, like what are the typical changes, like we talked about velocardiofacial syndrome, So what are the combination of things you get in there? All right. Where do you get butterfly vertebra? So it's basically how you put it all together. Vactral, you heard of vactral, VACTERL. So they will give you a picture of vertebra. Then they will give you a picture of cardiac problem. And then you have to add it together, and that is vactral. So that is so tracheoesophageal fistula. Now you will have to, unless you get used to seeing what a tracheoesophageal fistula, the X-ray or the dye test looks like, you see lots of it, you won't do it. Posterior urethral valve, Alligale, yes, Alligale does come up. Posterior urethral valve, unless you've seen lots, and believe me, for some reason I find in the exam, they give lots of posterior urethral valve pictures. DMSS scan, you have to know, it's not difficult at all. Go through Paul Guan. DMSS scan, what is your finding of DMSS scan? It's all given so concisely. Paul Guan is one of the books where it is given most concisely. Also illustrated textbook of pediatrics. How it looks like DMSS scan, what is it for? DTPS scan, what does it stand for? How does a posterior urethral valve looks like? Or even if you got a what do you call it, stenosis or hydronephrosis sometimes. How does it look like? You have to get, your eyes have to get used to it. Because the exam, the second secret is first is familiarize with the pictures. What is the second secret to crack the exam? AKP? Anyone? We'll finish now. Second secret, what is the second secret to crack the exam? Deepak, I might be able to answer. I think it's dinner time now, so I think everyone's getting old. Okay, second picture is time. You have to practice within that limited time. You can, when you are at leisure and you're going to the books and going to the pictures, you are taking a lot of time. Unless you prepare yourself, that's why I'm doing this, and I'm going to do, if you're happy with me to do this, then I want to do it once a week for the next few weeks, at least, where I want to do as many questions as I can. If you get better, I promise you. There was some unexpected events in the last few days, which made it very, I could not prepare as well today, really. It was, there was going to be more questions, really. But anyway, the only way forward is to do as many questions as possible, data interpretation, and how fast you can get your eyes to get adapted to the patterns in the chest X-ray, patterns in the MRI, patterns in the recognized patterns in the EEG, patterns in the skin, and that's how you break the exam. That's how you crack the exam. It shouldn't take time. Okay. Any last minute thoughts? So was it good today? How do you rank it? How was today's session? Was it okay? Good? So? Tanushri says good. Thank you, Tanushri. Others, I'm just waiting to hear. Then we'll say bye-bye. What's your feedback? Was it reasonable? Did you find the session useful? Was it stimulating? Others are very quiet. So either you're here or you've gone to sleep. Thank you, Deepa. Yes, thank you. You'll get better. Yes, I can guarantee it will get better. I think this was just the starting, so it took some time to get used to the system, because we are using Zoom webinar for the first time. I think now everyone knows how to use Zoom webinar. So Pooja is saying useful, okay. And I think we'll cover more, more pictures in the next few sessions. Anyone else? Soma, what happened to Soma? Wonderful questions. Yes, I thought these questions were very useful. For Deepa, you passed the exams, as you know. They were reflecting the actually what the questions which keep coming up in the exams. If you get these right, if you get the that's why I spend so much of time in the explanations. Because you believe me, when the next time you get questions, if you got the basic concepts right here, you won't have any trouble. Okay. So, any other comments? Where is Shravya? No comments from Shravya. Soma, where are you guys gone? Shravya has no answer. Useful. Okay. So, would you guys be interested in coming and further sessions like this? Obviously, as I said, be more streamlined, more to the point, and you won't be wasting so much time trying to get everything started, because today was a sort of, we can see a test session, our first session, so there were some technical things we're getting used to. Yeah. So are you guys happy for us to do it on? I would usually prefer to do it Wednesday 8 p.m. Would this be useful? Just type yes or no or whatever. Or doesn't matter. Or would it be useful? Yeah, Wednesdays would be all right. Yeah, 8 o'clock. Anyone else? Which is the RCPCH data interpretation book? Any name? I don't know. Deepa, can you help? Yeah, Wednesdays are okay. Okay. Wednesdays are okay. So I think someone can help. Tanushri is the name of the RCPCH data interpretation book. Shravya is saying yes. Okay. So I'll do that. And please get your friends or anyone. And I'll start on 8 p.m. sharp. I promise you today, as I said, we got caught up. So next time I'm giving you a link, please register your book. Yeah, AKP book. So it is just royal. If you do RCPCH AKP, it will come up. Okay, Tanushri, I don't think it'll be a problem. It is there in the Telegram. By the way, the link is there in the Telegram. In the Telegram group, it is there already. You can download the book. Okay. So thank you, and won't keep you any longer. Look forward to the next. I think the next Wednesday we'll make another one. Okay. So, and as I said, you can feel free to share your thoughts, suggestions in the Telegram group, and what sort of things you want, and keep preparing. All the best. Good night, guys. Good night. Okay. Good night.